Thanks again for joining our Lunch and Learn, where we're going to consider the procurement pathway and some information and recommendations, especially when looking to advance any NHS IP and ideas. That's myself up there. I'm Frances. I'm one of the Innovation Commercialisation Managers. And if you do have any questions during today's session, if you can just pop these into the question and answers part of the webinar or the chat box. My colleague Gillian Henderson, Head of Procurement Management and Commercialisation, is here joining me, and she will help to pull them together and hopefully address them at the end of the webinar. So we're joined today by David. So just a little bit about InnoScot Health. We were established in 2002 to protect and commercialise NHS IP. It's quite a unique role, and we are publicly funded and not-for-profit organisation, and we're funded by the Chief Science Office. We assess around about 2,200 ideas every year, and select probably about 9–10% of them to progress. We focus mainly on the commercial strength and health, economics and benefits that would bring. And hopefully by doing that, we get a good financial return to the NHS and our innovators. We were rebranded probably about 5 years ago, and so some of you might know us as SHIL, Scottish Health Innovations Limited. So as I've said before, we were funded by the Chief Science Office to provide tech transfer services to the NHS. We've got over 20 years experience now, in fact, probably nearly 25 coming up. And we work in partnership with the NHS health boards to hopefully inspire, accelerate and commercialise some healthcare innovations born from the NHS. We do have a lot of expertise and support, and we've unlocked quite a lot of NHS know-how and support sustainable innovation where there is like a commercial potential. We are a multidisciplinary team. We're quite a small team, and we empower and inspire Scotland's diverse and dedicated healthcare staff. And we hope to do that by having sessions such like this. Currently, we've got about 18 licenses and generate some income from those, and royalties as well alongside these, probably generated about 250,000 in the last couple of years. We've got an estimated potential value with our spin-outs as well, as you can see there, of over 30 million. Our focus now is on commercially viable projects, and we hope to deliver a financial return to both the NHS and innovators, as I've said before. So without further ado, I'd like to introduce David to you. I'm very pleased that he's able to join us as our guest speaker. And as you can see from David's profile, he's the Innovation Programme Manager for NHS National Procurement. So David's going to discuss and lend his insights on how innovation can help to provide the best possible care to our patient population. So as well as this, he is hoping to share his recommendations to anyone who may be a potential NHS innovator with an idea. So I will now unshare my slides and hand over to David. Is that okay, David? And I'll let you kick off.
Thanks, Frances. You lured me here with a lunch and learn, but
I've no lunch. I know you've got to get your own lunch, I'm afraid. Sorry about that.
Yeah, I was expecting some nice sandwiches sent through the post or something. So let me just share my screen. So Frances introduced me, so I'm the Programme Manager for Innovation at National Procurement. And I've met a few of you guys on the call. Certainly I can see David Logie's in the call. David and I joined the service about the same time, and probably about 20 years in the service. So I run, along with Scottish Government colleagues, the Scotland Innovates web portal, where industry and academia can send in their innovative ideas and solutions, etc. And we then look to triage to the correct landing zones to see if there's appetite, clinical appetite, to trial, do tests for changes, etc. We're working at the moment quite heavily in prostate cancer. Scotland being having the worst statistics probably in Europe, with 34% of men who come at stage 4 are dying, with the options in Scotland to operate or to radiate. And there's a lot more things in the market in Europe, etc., to do different types of procedures, and that's what we're looking at. We're working with a professor in Edinburgh at the moment at targeted radiation on the prostate and reducing doses from 25 doses to 5 doses, which creates a better patient experience. If you can imagine you're a man on the island of, say, Barra or something, you're maybe going to the mainland to get all the 25 procedures, when you can reduce it to 5 procedures. So we're looking at that, and we're looking to see how we can accelerate that. So these are some of the things, and these are things that suppliers have came to us and submitted their ideas. So today I'm going to kind of talk about innovation, and I'm going to talk about the different things that procurement do, etc. So the first up is who is NP, National Procurement. A lot of you guys will know what we do, right? So we are looking to do, and we've always looked to do, national approaches. The frameworks we put in place are for the whole of Scotland. So the hips and knees that you get couldn't be the same in Dundee as they are in Glasgow, so there shouldn't be any postcode lottery. And that's what we're trying to do in innovation as well. We're trying to stop the localised, a health board putting in a digital system, the next health board putting in a different digital system, hence fueling a chaos machine. And the explosion of digital since COVID has been massive, with the introduction of like ChatGPT is bringing in so much more new technology that we'd never looked at before. We used to buy, most of our things were analog. We did have some digital, but now everything that's analog is coming with digital. Our MRI machines are coming with AI. You cannot avoid it. But when do you jump on the bus to actually adopt it? When the market moves is really, really fast. So we are the sole buying consortium for 14 acute boards. And Scotland's a population of over 5 million, and we've got 172,000 staff in the NHS, 32,000 suppliers, and over 450 national live frameworks. And our spend is over £3 billion a year. And that's drastically went up, say, in the last 10 years. Agency labour is costing a lot more. There's a lot of staff vacancies. We're having to use a lot more agency staff, locums, etc. So we're spending a lot more than we did. So we've got three major distribution warehouses, and we run 24-hour pick and pack, and we ship 80,000 items to all of the health boards. So when I'm talking about digital, right, this is what the digital estate looks like in a small country with 5 million people. And you probably want to question some of these things. Why we've got 1,300 websites, 15,000 servers. So it looks really quite vast. So if you've got an idea, think about the estate, think about the integration you would need to do. When there's different versions of track care in different hospitals, how do you integrate with that kind of stuff? The next slide here is what do our teams? What teams do we have? So we've got I think we've got about 100 buyers. So you can see here the different teams. It's pretty self-explanatory what they're buying here. And when we look and we go back to AI, again, AI in medical equipment, yeah, MRI, X-ray. There's AI in every single area here. Non-medical, food buying. There's AI portion controls that are being looked at, so that the patient gets the right amount of portion. There is less wastage. You're dealing with, you can report on your food wastage, so you can reduce your CO2. So it's happening in every area. So let's focus in a wee bit on what the teams actually buy. So our IT teams, large scale IT infrastructure, as you'd see, these guys are working along with Education for Scotland with the NHS front door that's coming in, hopefully answering a lot of questions of different procedures, etc. There's a big explosion in all disciplines, MSK, mental health, etc. could the NHS front door be somewhere that, you know, you can be pointed to the right area? The medical equipment team, they are buying MRI, CT, and recently bought quite a lot of Da Vinci robots. Some of you guys will be familiar with the Da Vinci robots. The Da Vinci robot representative contacted me recently and says, our Da Vincis have moved on to version 5, and we only bought the version, whatever we bought. The new ones are better, but again, you've just spent 20 million. You just couldn't go and spend another, you know, as I said, technology is moving faster than we can move. So how long do we keep the machine? How long should we keep the machine? So these are all things, these are all kind of types of barriers in procurement. The medical surgical team, orthopedic implants, agency labour, syringes, the paramedical, dressings, wound products, everything, all the things that are in your cupboards in the hospital, they're coming for the buyers who are putting frameworks in place and our distribution guys who are shipping it to you. So innovation, what is innovation? How do we procure innovation? Where do we start? Where do you start? And what products are required? So innovation is the implementation of a new, significantly improved product, service or process with the purpose of helping to solve societal challenges and support smart, sustainable and inclusive economic growth. It's as easy as that. So from the NHS standpoint, where do we start? So we need solutions to solve a multitude of service problems. And these need to be low friction and scalable across 14 acute boards and 6 special, able to interact with current systems, surpass current systems, be affordable and not a me too product. As an NHS staff or an SME or a spin out, you need to understand our problems, understand the customer, the total need for clinical buy-in and an appetite to engage, proper regulatory accreditation, and we'll talk about accreditation later. You need to evidence viability, feasibility and desirability, and we'll get to that slide. So this list is not exhaustive, right? These are the areas, you know, every day there's a story in the news about, you know, the story recently was complaints in A&E waits for over 15 months, 2 years, etc. for hip implants. So the areas that we're looking at here, and some of the areas that are about to be the first adopters of the AI, are radiology and endoscopy. But there are some barriers to the AI. So the radiologist is, you know, may say, you know, this is good. This new system is spotting more anomalies in the scans than I'm seeing. But the radiologist is now required to take more biopsies, more samples, and send to pathology, who then have to do more analysing and more reports. So it could increase the workload. But I'm sure the AI, as we go forward, will get much better as it learns. So in the future, I think these will be really, really good things that will save a lot of time and potentially save more patients catching things earlier. We're also looking at diabetes, cancer, heart health, mental health. As I said, prostate, we're looking at the prostate. And mental health, we're doing a project with policy leads in Scottish Government on ADHD diagnosis, dementia. Then the main big things is casualty, improving the pathways, reducing the waiting lists, A&E, reducing hospital attendance by remote monitoring. And then for sustainability, reduce of single-use plastics, transition to net zero, low carbon technology, circular economy. And then particularly in circular economy, we're looking at another project for replacing lighting within the hospital environment, taking it away and remanufacturing it and bringing it back and putting it back in where you're using the same parts and they're just, you're modernising them. You're bringing it back at 60% of cost than new. So there's quite a lengthy paper on that at the moment. It's going through Scottish Government about trying to install that type of circular economy. So when we advertise in procurement, we have to put it through Public Contracts Scotland to advertise that Scotland, our national procurement, are going to the market for a digital system, are going to the market for orthopedic hips. And that's a public tender. But we also put other notices up and other documents. A lot of the time we use prior information notices. We want to find out what the market is in a PIN. We want to find out what the market is if it's a fast-moving market in digital, what's currently out there, what suppliers are currently supplying to, say, maybe NHS England. So before we do any tender, we're scoping the market. Our contract notices, our tender notice, we put that out, telling you we are looking for tenders for certain things. And after we've done that, we put an award notice out and we say we've now awarded the contract and these are the suppliers we've awarded to. We may put a notification, a modification, where we're saying we're going to take a year's extension on this contract. So we tell the market and we're very transparent. Selection criteria. The selection criteria is we telling the market what the selection criteria will be, what you need to do to get pass muster for the tender. And then the dynamic purchasing system is for very fast moving areas where you set up the system and the contractors can then pass a qualification questionnaire, and then we have a bank of suppliers we can use when we want to move into something fast, something say in the digital realm. So I'm going to break out the presentation here and show you something on Public Contracts Scotland, and you can, if you get that slide deck, on Public Contracts Scotland, go to Information and Support and download the forward plan. Now the forward plan looks like this, okay? It shows you the main buying consortia in Scotland. Scotland XL, who buy for 32 local authorities. NHS National Procurement, 14 boards, 6 specials. APUC for universities and colleges. Scottish Procurement for the bigger things, oil, gas, electricity, etc. So if you look at NHS National Procurement, this shows you our 450 national frameworks. I'm not going to go zoom in too much, but what it will show you, live contracts. This sheet shows you live contracts and who we actually buy from. It tells you the supplier that we're getting the goods and services from. It tells you when the contract starts, when it finishes, and it tells you the name of the lead buyer. So you may be in the NHS and you've got an idea, or you think, okay, is there anything out there? Could I be adding to this contract? I think a new device could be added to this contract. Who do I contact? Who do I talk to? Right? So you can talk to the lead buyer. You may want to be involved in his or her CAP, commodity evaluation panel. And by joining that panel, you can then specify what the next iteration of your contract should be. So you get your voice heard. You're in Forth Valley, and you say, in Forth Valley, we've always have a problem with this. If this was added to the contract, this would really help us. So this is getting involved. The forward plan, the green tab here, this shows you everything that we've not done yet, everything that we're going to do. So you may say, well, I'm going to create this new device, and look here and find out we've actually thought about that, and we're actually going to go to the market with this, with lots of digitization, different things. So down to the like frozen food, direct meal services, orthopedic trauma, extremities. All of these things is worth consulting to see what we're doing, and then you can see who can I speak to about it. So it's always good to do that. That the transparency that we're telling you what we're going to do and what we're going to procure in the future. And there's a vast amount of digitization that we're doing, a vast amount of contracts we have in the digital area, and you can see they're very much up at the top of the sheet here. Loads and loads of different digitized contracts. Let me move back to the presentation. So what does NHS Scotland look for regarding innovative goods? So this is me. I created a wee AI picture. This is all the innovative ideas in every discipline you can imagine is beating on the door. Try us, take us, but not a lot of it gets through due to the barriers, and we're going to get through the barriers. But there's funding, staffing, reluctance to change, ethics committees, lots of different things that make it slower. So there's loads of stuff that's on the market right now that are coming and beating on the door. So the attributes for a successful innovation are, and I said this earlier, desirability, feasibility, and viability. Feasibility. So innovative product service must evidence improved life expectancy and quality of patient life and a reduction of disease and avoidance of future healthcare demand. Desirability, somebody needs to want it. There needs to be clinical input. Want something. If you don't want it, there's nobody ever going to buy it. So innovative product service must evidence that technology is relevant for national adoption. And that's the point. Once for Scotland, national adoption. Of patients, it must benefit clinical desire and innovative products. Clinical support for adoption is essential. Evidence should be noted. And then, how much is it going to cost? So the service must have evidence of increased efficiency, NHS potential for reduced costs, anticipated realised savings, etc. So I think we all can understand it's got to save us money, it's got to make us more efficient, help us reduce backlogs, improve pathways, improve patient education, patient experience, etc. So here's some of the barriers to adoption. So we're talking about AI, it's moving fast. ChatGPT 4 is now ChatGPT 5. And I think round the corner, advanced general intelligence may be landing in 2027, which is going to be a game changer for health. Things it will explode with the different types of AI algorithms that we're using in health. But we're slow to respond because there's challenges incorporating digital solutions into existing analog systems. Systems have been in place for many years. Hard to unpick, especially when you're trying to do a national approach, board to board, when there's different systems in place. Risk averse. Extensive evidence of accreditations is needed. I'm going to talk about accreditations in a minute. The emerging change in governance and funding arrangements. A lot of clinicians will be writing SBARs and saying, look, this would really help my department. And finance say, well, there's no budget to carry that out. And they look for other areas such as endowment funds and maybe even charity donations to see if the funding could be seen there. But the service is cash starved with the amount of spend that we're currently having to do anyway. Securing funding for research and development, trials, adoption and implementation, staff reluctance, resistance to change, challenges gaining stakeholder buy-in, and I've said before, staff vacancies, staff retraining, and can it fit in with current tech and pathways? So the accreditations, and this, I could probably run this into about 3 slides. So if we look at digitisation, innovation, evidence is going to be needed, and suppliers and anybody want to create, and you need to know about these things. They cost money, they take time. So having things like DTACs in place, which is your digital technology and assessment criteria, it's a 37-page question set that includes things like DCB 129, which is safety. It includes your cyber essentials. It is absolutely essential, especially when there's so many stories of NHS boards being hacked and patient data being released. So having ISO 2701 and Cyber Essentials Certificate, these are standard things that need to be in place. And also thinking about your GDPR, your DPIA, also backing it with your MDR, your medical device regulations in 13485 and ISO 9000. And then we go into the ISO, we get into the AI, the EU Act, ISO 4201 is the gold standard at the moment for AI. And I do have other information, but I don't want to just blow your mind with just everything here. So you're thinking about you're moving to your CE classes, getting your CE certificate. You've got your class 1, 2A, B, and 3. 3 being the highest risk one, where it's things like it says here, prosthetic heart valves, breast implants, to the medium ones, which are ventilators, etc. So knowing where your product will lie and what accreditation you need for it. So I'm nearing the end of the slides here. So the commercialisation, the customer, me, you, the NHS. The NHS wants predictable, inexpensive, low friction, ethical, regularly approved, safe and secure products. The process, understanding who holds a budget and how they approve expenditure. There's normally a stringent business case. So for anything that we're ever going to do, there has to be a business case, a value case, and it has to be signed off. We recently, about 2 years ago, we were contacted by a clinician in Glasgow who had a problem with backlogs for atrial fibrillation. And he told us that on the market in England, 35,000 patients were utilising ECG electrode patches that had an AI aspect to read the traces. And he was looking for funding to try and move that into his department. So we took that to the Accelerated National Innovation group, and over the last 18 months, etc., value cases, business cases were put through, and we're about to roll this out with full rollout by, I think, October next year. And by doing this, it'll improve the backlog, because what happens when you put the current way of doing things, you go into clinic, you wear a Holter device, and it measures you for 24 hours, say. And a lot of times your atrial fibrillation is not discovered in that time. You've got to get back to the hospital, hand it back in. Then a clinician has to read the trace. The new ones are remote. You don't need to come to the hospital. The patches are sent to you. You put them on, and then it's read. It's read by a company who then supply the information back to the clinician, and it takes a lot of time at the service. So that's coming. So understanding how business cases come about. I'll move on to the next slide. Commercial lessons from people that have tried to do things and bring them into the NHS. It's a difficult journey. So the company didn't understand the commercial journey, and they weren't prepared. Didn't have the right skills to deliver. Built a product that doesn't solve a common need. Didn't understand the clinical operation pathways, so his product wouldn't fit. Again, going back to, will it fit into current systems? Overestimates the value and underestimates cost, time and resource. Didn't gather evidence relevant to target deployment environment. Thinks about the user, but not the customer and the buyer. Thinks about the technology, but not the experience and scalability. Could use an SME? Could you scale to 14 health boards? Unprepared for information governance, security, compliance and regulation. Doesn't protect intellectual property and create a defensible market position. So move on to the last two slides. Scotland Innovate. So what does my department do? What do we do? So Scotland Innovates, an informative one-stop shop service allowing users to easily navigate their journey, appropriate signposting for innovation services, as I've said, finding the right landing zones, etc. And we look at all push innovation solutions that meet the criteria. We can then move them to the Accelerated National Innovation approach, just as we did with the ECG patches, as we're trying to do with the prostate and the ADHD projects that we're doing at the moment. And my last slide here says, so if you have a truly innovative product or service that's near or on market, register with Scotland Innovates and submit your proposal. Thanks for listening to that. That's me finished. I'll just stop sharing.
Thanks very much. Really interesting stuff, isn't there? There's a lot going on, and funnily enough, I forgot about the commodity valuation panels, the CAP panels. They're really, really useful tools. So thanks for that. I'm just wondering if there are any questions from our audience.
Yep, there's some had some questions in the chat. David, the first one is for you, obviously, and it's around differences between the English and Welsh system and what we have in Scotland. So in NHS England and Wales, they have a centralised procurement model for high-cost tariff-excluded devices. Do we have that in NHS Scotland? And if not, do we have an equivalent? It's a new one for me.
Yeah, rephrase that. England have got a centralised. Well, England have got they've got a version of Scotland Innovates, and it pretty much mirrors what we do. But they basically send to clinicians, where we send to national groups. You know, if I get something in diabetes, we go to the National Diabetes Innovation Group. If it's mental health, we're going to policy leads in the Scottish Government. So we're going to the higher levels of people that can make decisions, you know, and we'll ask questions such as, should Scotland have a national cancer IT platform? Should Scotland have a national MSK platform? Should Scotland have a national ADHD platform? Rather than, you know, if you look at MSK, Glasgow put something in and Lanarkshire put something in, but they're different. So should we continue doing that, or should we look for national approaches? So that's the level we're at by using ANYA, DHAC, and the commodities we currently buy. So the pathway, if something comes in orthopedics, we've got an orthopedic cap and an orthopedic contract, and we've got the clinicians behind that. If it's something that doesn't fit in there and it's digital, it can go to the digital health and care for consideration. So I don't know if that answers the question. I don't think it really does, but
maybe just a different way of triaging things that come in. I have to say I'm not familiar with the HC TED down in NHS England and Wales.
No, none of myself.
Okay. The other question is, what is the selection criteria for InnoScot to consider a new innovation? I can probably take that. All innovations that come in are assessed. We largely look for novelty, feasibility, resource that would be required, whether or not it can be clinically implemented. Similar process to what would be considered by procurement, but obviously at a very much earlier stage. If you have a concept, an idea that you're looking to have reviewed by the team, please just get in touch and we can have a look at it for you. Another question just come in. We are an NHS doctor-led medical recruitment agency with a soft SaaS solution. Where do we find procurement opportunities for recruitment?
All opportunities are advertised in Public Contract Scotland. You should register with Public Contract Scotland and pick your CPV code alert. CPV, David, what's that? That's just your procurement vocabulary. You pick, I'm a company and we are interested in furniture. I'm a company and we're interested in orthopedics. You know, you pick. And when anything that's been advertised, so we put a pin out, we're going to tell you that we're coming to the market. We put a tender out, we're saying you've got 40 days to tender for this. You'll get an alert. You'll also see the forward plan that I showed you. That's telling you what we're going to do in the future. Priority is putting a pin out. So we'll tell you the forward plan. We'll then tell you if we put a pin out, and then we'll tell you third that we're putting a tender out. So we're very transparent. If you've joined Public Contract Scotland, you shouldn't miss out on anything that's coming up. And I would always browse the notices as well. I'd always put in keywords to see if anybody's doing something. The NHS may be doing something, but academia might be doing something similar. You know, they might be doing proton beam something in Aberdeen, and they might be looking for accelerators and stuff like that. So academia do a lot of NHS trials and stuff like that. So we'll be looking at these guys as well. But always keep going back to Public Contract Scotland, because it will tell you when we're doing things and what we're doing.
Okay. Another question around scalability support. So what scalability support is available for companies who have managed to achieve local adoption but are looking to scale nationally?
Aye, so that's a question. I'm talking about the cancer policy one. So we've got a company that's in 2 health boards or 1 health board, right? And realise there's other people in the market that are doing something similar, but they like to scale. So that's where when the companies come through Scotland, and we'll ask the question, would you be happy for us to take this to a national level, right? Would be happy for us to ask the question, should there be a national approach? Bearing in mind that if we do go to the market, there's no guarantee that you, the company, will get the gig, because everybody that can provide these services will have the same chance. So we will ask these questions. You know, that's the scalability. should there be a national approach.
Okay, so it's not an automatic rollout.
No, it's the other way of doing it is national procurement will periodically look at the spend. So if a spend starts to increase nationally in an area that previously there was no framework, we'll look to onboard a new framework into our portfolio. So digitisation, you see the IT team, say 10 years ago, they didn't have a lot of contracts, but they've now got, I would say about 10 times the amount of contracts that they did because of digitisation. So they can see that health boards are starting to spend a lot more money on digitisation and then look to pull that together and then scale it to a national approach and then advertise for a national approach. So if we looked at the cancer platform, our IT department would then tender for it and the specification would be made. All suppliers could meet that specification. The CAP would then score it and then they would pick one supplier, two suppliers, maybe multi-supplier to supply these services across Scotland.
There's also a question here regarding, so someone has an NIHR project currently being funded for trials. So it's obviously very new and novel, and they've made a comment that no procurer knows specifically to put a tender out for this. What would the first steps for something like that be to go through a procurement route?
Well, Jim, a lot of people say procurement is the barrier, right? But if you bring procurement in at the start, procurement can guide you, because a lot of suppliers may come in, they get a trial and they think, yes, that's us, we're going to get the gig, but you don't get the gig because it has to be advertised and it has to be done transparently. But we have our innovation test beds, one in the north, one in the southeast and one in the west, Glasgow. So things that are low TRL, they can go to these test beds. And the test beds can then help them commercialise, increase the TRL level, your technology readiness level. Scotland Innovates looks at technology readiness level 8 and 9, near market, on market. We're looking at things that are on the market, actually being used in, say, NHS England, things that are on the doorstep that can help problems now. The test beds are looking at things that may be a few years from market, but they have some promise. But if you're at a lower level, the test beds, you can easily Google, West Innovation Test Bed, Grampian Test Bed, etc., whatever geographical area is closest to you.
Okay. There's some good information in the chat for those who are interested in the HC TED. I'm calling it HC TED. So there's some good information in the chat there for anyone who's interested. Thanks, Sue. And I think we've covered all of the questions in the chat. Thank you very much, David.
Thanks. Anybody that wants to reach out to me that have had a question after the event, just reach out to me and we can have Teams calls, etc. We can go more in depth. I could have went more in depth because there's a lot more, but for the time that I had.
Thanks, David. That was really, really interesting. I know you've got another meeting, so feel free to pop off if you want. I'll just finish up here.
Thanks
a million for coming.
Thanks. I'll see you soon. All right.
Yeah. Thanks a million.
Bye.
Bye. So just going to finish up then. Thanks a million for joining us. I think it's been really, really interesting. There's been a lot of points raised. And as you can see there, we are here to help. So if you do have an idea, please do reach out to us and we can put you in touch with other organisations as well. Just to finish and say that we are continuing this webinar series and you will be able to catch up on our previous webinar playlists. The next webinar is going to be on the 29th of October and that's going to discuss the Clinical Entrepreneur Programme. So it's a really exciting programme for early innovation and entrepreneurship. So we can talk about that at the end of October. So hopefully you can come along and join in. And just really to thank you for joining us. Our QR code is there. If you want to take a little scan of that and keep in touch as well, you can sign up to our newsletter. And again, if you've got any questions following on from that, don't hesitate to reach out to the team. And we hope to see you again soon. Thanks again.